Femoral acetabular impingement is an injury that results from an altered morphology of the femoral head and/or acetabulum. It creates abnormal stresses on the surrounding soft tissues and bones, which can result in labral tears, chondral degeneration, and osteoarthritis.
Two types of femoral acetabulum impingement deformities exist. Cam lesions are located on the femoral head and result from an abnormally shaped femoral head repeatedly contacting the acetabulum and surrounding labrum, occurring most often in young athletic males. Cam lesions are thought to develop in response to extensive sports participation during the high growth period of adolescence. Pincer lesions are more common in middle-aged active females. They result when the acetabulum is overly covering the femoral head, resulting in compression between the acetabular rim and the femoral head and neck function. This occurs especially during hip flexion. A combination of pincer and cam lesions may also develop, although this is fairly uncommon.
We have a 23-year-old male soccer player who is complaining of a gradual growing pain that extends to his lateral thigh. His pain initially started as sporadic and progressed to constant pain. It is exacerbated by activity or prolonged sitting. Activities that reproduces his symptoms include hip flexion, such as squatting down or stair climbing. He walked in with an antalgic gait, and he presents poor hip control with squatting. The most common mechanism is repeated compressive forces from an abnormally shaped femoral head or acetabulum or both. With inspection, he will complain of deep pain in the anterior hip region. With active range of motion, internal rotation and adduction may be limited, especially with the hip flexed to 90. With passive range of motion, there is a decreased hip internal rotation when the hip is flexed to 90 degrees, and there's an increased pain with hip flexion. With manual muscle test, the hip external rotators are weak.
FABER test. To perform the FABER test, have your patient lie supine as shown here. Place the foot of the involved side crossing over the opposite thigh. The clinician should stand on the side of the patient that will be tested with one hand on the opposite ASIS and the other on the medial aspect of the flexed knee. The extremity is allowed to rest in full external rotation, followed by the examiners applying overpressure at the knee and ASIS. Reproduction of symptoms in the hip or sacroiliac joint is a positive test.
A positive test may indicate hip pathology or SI joint pathology.
To perform the anterior impingement test, have the patient lie supine. The clinician should stand at the side of the patient to be tested. The examiner then takes the involved leg and flexes the knee and hip, internally rotates the tibia, and adducts the hip. Pain or symptoms at the hip are reproduced with a positive test result.
A positive sign could indicate femoral acetabular impingement or labral tear.
The SCOURING test. To perform the SCOURING test, have your patient lie supine. The clinician should be at the side of the patient, fully flexing the patient's hip and knee. The femur is then internally and externally rotated with the hip at multiple angles of flexion. Pain or reproduction of symptoms at the hip are a positive test result.
A positive sign could indicate a possible defect in the articular cartilage of the femur or acetabulum or a labral tear.
Yeah.
Favorite test.
Yeah.